Welcome, everybody. For those of you who don't know me, my name is Emma Brown, and I'm the founder of Whimble. We are a care tech platform based in Ottawa. And my goal with Whimble is to build an Uber style platform for personal care, where people in need of urgent or short term personal care assistance can connect with vetted, experienced attendants on demand. I describe this as a safety net for care. We also partner with events organizers and venues to ensure they offer on-site attendance services as part of their accessibility accommodations for guests, volunteers, staff, anyone who needs extra support, including, shameless plug, right now at the Canadian National Exhibition, the CNE or the X, for any of our GTA-based guests. Come on out. And we have 2 or 3 attendants on site every day who can assist with everything from transporting people around the ridiculously large site to toileting assistance, help getting food from one of the many food vendors, et cetera, et cetera. So yeah, we're hoping people are taking advantage of that service. Speaking of Toronto, I'm so excited to welcome today's guest, Atticus Hawk. Atticus is a leader in the accessibility, healthcare policy, and harm reduction spaces with a focus on developing meaningful programs and tools to support LGBTQIA disabled and vulnerable people. During his PhD in information science from the University of Toronto, Atticus designed and delivered the first course in harm reduction for information professionals offered at any university in North America. This really shocked me, and we can talk about it later. Atticus, for anyone who tuned in early and heard us chit-chatting, Atticus is actually starting or will be continuing his studies as a member of the inaugural class of the School of Medicine at TMU next. It says next month, but I guess it's almost next week now, early September, not to scare you, with a focus on family medicine for street-involved and precariously housed people. So all that to say, I'm super excited for this conversation. I have a lot to learn on this space, and I'm really excited to pick the knowledge of Atticus with the amount of information you have in your brain on these really important societal issues. So thank you so much for joining us today. I know you have a lot on your plate, and yeah, just really appreciate you being here today.
Oh, thank you so much, Emma. That's a very deeply welcoming introduction. I'm always blushing red when somebody reads the shtick. I know that I had input on contributing to it, but oh man, my internal sense of shame is just coming and crushing me deeply right now. So if I suddenly wither, please forgive me. Also, please forgive me if I cough at any point. I'll try and mute for that. I'm fighting a bit of a head cold, and I've locked myself in my office, sequestered safely, so I don't lick anybody else. It's a wonderful time.
Try your
Thank you for
best
having me.
anyway. No, thank
I'm
you for
trying my
joining us.
best.
Yeah, so every time I read your bio, I'm like, man, like this is a very interesting background. So I would love to hear in your own words, like, how did you end up here? Like, what was the journey that kind of led you to pick up all these very diverse sets of expertise and knowledge?
Oh, dear. That's a question. All right. So, from the long and short of it is that I have a disability. I have a genetic disability that is not particularly visible all the time unless I'm in a particularly bad flare. I didn't realize I had this disability until maybe I was around 25 or so. It started to really impact my mobility and running around. I came from a really crummy childhood, and a lovely skill that sometimes people have is skill in classical music. I was lucky enough to utilize school programs to develop some skills. So by the time I was 16, I was able to get myself into university in a way. I know a lot of people who struggle with their childhoods, just being able to get out is a major part of it. I worked my body into the ground in classical music as a professional cellist from about 12 until 25-ish. So I worked myself to the bone for that quite literally. And my symptoms kept getting worse and worse. The body just couldn't take it. But I was fascinated with how information is passed, how different types and specificities of information enter from a student to a teacher, enter from performers to audiences. How we communicate information played a major role here as I'm trying to get people all jazzed about my fun cello concerts of music from 1807 to 1809, a very specific time period. And I'm like, oh no, it's different. I promise. Please listen. So trying to get people engaged in that kind of interaction. Around that time, a partner of mine also got very ill, and we were in and out of hospitals constantly, very constantly. And I realized that this manipulation of conversation, this learning about systems and the style of how information was flowing, misinformation, digging through records got me heavily into an archival sort of lens of looking at things. I switched my focus from looking at performance and performance studies, scooted through another master's, scooted into a dissertation, took lots of time because I knew being attached to a university was really the only way that I was going to receive certain benefits and funding for my physical needs and a little bit of income here and there as we really tackled systems that are terrifying and the needs for medications and the needs for support of any kind. Realize that I'm pretty good at medicine, but mostly realize that I'm very good at looking at the system and looking at systems of manipulation and taxiing people through them. And I started extending this skill during the very beginning of just a little before the pandemic really set in, is bringing people around, coming with them to their appointments, chatting with them about how to speak doctor and how to speak medical and how to speak home care and how to chat about different benefits and different access points, how to work with Ontario drug benefits, how to think about what kind of non-opioid pain medications you can suggest to your doctor, how to think about maybe now it's time to think about opioid pain medications, how to articulate pain, how to articulate discomfort when you've been in pain for your whole life. I know that's something that really hits a lot of people. How do you articulate something that's your normal? How do you articulate your limitations when they're not really limitations sometimes? They're just a thing you don't do. And but they're a limitation on a form, and they'll give you some money for that. How do you make this happen without hating yourself? So all of these questions really spooled around, and I realized that there was a big problem as I moved to the Faculty of Information to pursue questions around archival and how we categorize information and how we categorize medical information and information about queerness. And I realized there was a big issue in how information scientists, which encapsulate a lot of data scientists who don't love math, and every single librarian who is going to be like a truly registered librarian has to go through a faculty of information, receive this master's of library science, and they were not being trained on the unique issues that affect several, in fact, most of the patrons who use the library most regularly. They were not receiving training on the specific needs of people who are unhoused, who found the library as a major source of both medical, physical, and dignified access to care. It is the last space that's free, at least in Ontario, at least that I see of it, that has access to running water, electricity. It's cool when it's hot out and it's hot when it's cool out. And you can be in there. It's also regulated and it must be accessible. Not that it always is, but it is at the forefront of receiving that kind of thing. So this big crossover between people who are unhoused and people with disabilities, and oftentimes they are the same population, as well as people who use drugs and people who use drugs. Those are two different populations in some people's heads, of people who use pharmaceutical or prescribed drugs and people who don't, but they're still using the same substance and there's the same risk factors with them and the same need to have awareness and training. So I realized library students were already facing this. We sent out these a nice large examination of librarians and library workers across Ontario, and we said, hey, how many of you have actually responded to an overdose in the library setting? And about 50% already. This was before any training had been implemented. This is an epidemic in Canada that has killed over 52,000 people since 2016, since we really started tracking. The harms are off the chart. This is a very scary thing, but it can be alleviated by understanding how to recognize an opioid overdose and how to administer naloxone. Naloxone is a medication that reverses the effects of an opioid poisoning. And that's great because people start breathing again. Anyway, very long story short, working with systems to interact with those pain points and go, hey, there's something we can do here. There's a group of people who can actually really save a lot of lives. And then expanding that outwards and looking at it as what are librarians? What do they do? What can they do? A library is more than just repositories of beautiful, wonderful books. It's a place for all sorts of people, especially people who experience financial issues because not everybody is wealthy enough to be at home. Sometimes We are outside our home, and sometimes we would like to leave our home, and sometimes we like to get out, and
Mhm.
sometimes it's just nice to be out.
Yeah.
So this was the world, and I wanted to
And some
really look at these things. Yeah.
Amazing. Yeah, and sometimes you need an air-conditioned space because it's 40 degrees for
Oh
weeks on
yeah.
end and there's no cooling centers available. It's
Yeah.
I love that you've both looked and observed and researched the issues with a very academic lens, but then you're also like getting your hands dirty and like getting in there and introducing these courses, going back to med school to offer that hands-on support because I find sometimes academia can be very good at being like, here are all the issues from the lofty ivory tower, but then obviously not really doing the like solution side of it. So it's amazing to hear how your experiences have been both observing and then introducing solutions as well. Amazing. My next question was actually going to be about the harm reduction course because it did shock me that this wasn't
Yeah.
already a standard practice because like librarians are becoming essentially frontline support, frontline healthcare workers, like frontline social workers, like they're really embedded in that space. I guess was the feedback from the people you surveyed, I would love to know more, or were people pushing back saying, I would rather the focus being put on the library not being the only sanctuary available for people? Or what was the feedback from the librarians that you work with?
Yeah. A really great question. Unfortunately, like many things, feedback can be noted in stratas of different people who think it's their problem or not. The overwhelming majority of people who were in those frontline positions or in managerial sort of frontline positions, which libraries across Ontario will structure themselves a little differently, across Canada will be very different. Everything's a little different everywhere. But the people who were generally right there, they're dealing with patrons, they're very interested in caring for their patrons, were saying, it's at a point now, we just need a solution. We need to know what's going to happen because I'm responding and that's scary. For example, just in the Toronto Public Library, which is the largest library system in Canada, I believe, actually in North America, to be honest, in 2024, there were 109 suspected overdoses and there was one fatality within the library system. That's a lot for staff to be dealing with. And frankly, I can't stratify by library system. Our respondents were anonymous on purpose. It was to protect their positions, as this can be a contentious topic. Overwhelmingly, they just said, as much as I don't like that this is happening, because nobody likes to go to work and be like, a crisis that I wasn't trained for and don't like this is not in my job description. Nobody wants to walk into a crisis that's not in their job description. But overwhelmingly, it's just, we can't keep going. This is a thing. I need to know how to do this. I need to know how to, I can't deal with watching someone die. And frankly, when you look at it from a very cold perspective, from the non-human perspective of labor and non-human perspective of impact on people needing to take time and needing to take bereavement and needing to take that recuperation of watching somebody go through a crisis and not knowing how to help and go through a crisis and feeling helpless and maybe go through that crisis and actually seeing ultimately someone not make it through that crisis. The amount of pressure that puts on a labor system is extraordinary. The amount of financial drain that will put on a labor system by re-traumatizing your employees multiple times is enormous. So actually equipping people from that pain point before the pain point starts is actually a cost-saving device. And I'm like, I hate that I use this particular framing of it, but I'm actually very serious. I think that harm reduction is the cheaper method. And I think that really preventing people from having to respond when they don't know how to respond reduces the amount of trauma that comes out of a response when you must do it anyway because you don't want to see someone die. Having a tool and knowing how to do it is, how nurses avoid being traumatized by seeing death all the time. They know what they're doing. So it's not the question of do people like people will argue. Of course they'll argue this isn't the right place for them. And I'm like, I'm sorry, but the rules of library are that is for everyone, and that means society's everybody. So we gotta go from there.
Yeah, it can be. I find it also very frustrating to go back to capitalism and be like, this is a cost savings measure. But we often have to use that argument with Whimble as well of
Of
providing
course.
on demand personal care assistance is a cost saving measure when you compare that to someone's like health condition getting worse and more complicated to treat and requiring a hospital stay or more intensive intervention. And so it doesn't feel great to have to talk about the dollars and cents when you talk about human beings, but it's the reality of the system we work within.
Absolutely.
I'm curious in whether you're working with other healthcare professionals or whether you're working with students in your research, like how are you finding we're having some of these conversations as well around like how people approach consent, dignity,
Mm.
trust in the context of care. So I'm curious, like, if you're finding very diverse approaches to that, or if you're what trends you're seeing in the work you do around those concepts.
Definitely. Some of my work definitely, I come preordained, as one might say, with being like, oh yeah, you have a PhD and you're from this school and you're doing this. And so you're relying on your legacy of whatever somebody values in that. And there are lots of people who, for that particular legacy, is a red flag immediately, and as it should be. So for people where I know that my legacy is a red flag, I approach them with the absolute honesty of here's who I am. Here's what I research. I don't really want to talk to you and take anything from you. I would really love to know, say, if I'm approaching somebody who uses substances and I would like to have a little bit of an overview of a site or people, and I'd like to just know what they would like, what they would want. Right now, I'm working with the Ontario Drug, oh God, it's got a large name, the ODPRN, which is out of Unity Health, which is St. Mike's and Providence Health and St. Joe's. They have a research wing and they were nice enough to take me on. We're looking at naloxone dispensation practices in pharmacies. What we'd also like to look at is there's no actual research on it. We'd like to chat with people who use drugs and ask them, do you prefer the nasal administration of naloxone where you put it up your nose and you get a little spritz? Or do you prefer the injectable into your muscle version? In the side effects that you come out of an overdose, which one makes you feel less shitty? I think that's a completely legitimate question. This is a disability. This is a major treatment and immediate reversal. But I do think that we should really care how terrible the nausea might be afterwards and how terrible it feels afterwards. So we'd like to chat with these people. And so how we're going to chat with these people is we're going to say, hey, this is who we are. Can we chat with you for 7 minutes? I bet $25. Are you up for verbal consent? Are you up for this? You're not? Okay, cool. Thank you. Do you know that maybe your friend might? Is that all right? So developing that, chatting, and also being around. I'm a very recognizable person as I'm running around different areas of the city. I've responded to quite a few overdoses, sometimes with my partner, more often than not with my partner, as we're horribly inseparable. And we're running around, we're responding. People do recognize us. And we're not rude. We are kind about things. People do remember if they saw you responding to their buddy overdosing and you pulled up his pants so he was not exposed while you did it. They will remember that because that is a small, almost insignificant act of dignity that truly does matter. If you take the second and you can take the second to alcohol wipe the skin before you give an injection in an emergency situation, yeah, is that require is someone gonna get a horrible infection? Probably not, but they just the little trust, the little dignity, the holding someone's head, the fact that people feel comfortable to ask certain people for change versus asking somebody, "Hey, will you buy me a beer?" That's a different level of trust. And knowing that you can actively engage in these things and knowing that there's a certain saturation point of trust you'll end up at that you could maybe ask a question or two about what you might want to know, being very transparent about who you are. For example, when I've interviewed people on occasion, I do always show them my full ID. I show them my name. I say I've got a really recognizable name. If you Google me, only I come up. You're welcome. Here's where I work. If you have questions, you're welcome to contact anybody. I am confident in anything that I say or do. I put my whole public and even private persona on the line for what I do. And if you don't like who I am after looking me up, you don't have to talk to me. And just being really aware that somebody's comfort is more important than my research, and always is. Even if my research is very important, there's always another way to get that information. I feel like I'm going around in a circle. I'm terribly sorry. I could say a lot about dignity. I have a lot of the dignity and the respect for people as you do things will always be noticed. I also find that with doing care navigating and personal care work, the tiniest dignities that feel like nothing, angling the straw just so somebody doesn't have to ask, making sure it's their preferred vessel, putting a coaster down if that's what they would like. Tiny things where you're in somebody's space, up in their face. All these things really
Yeah.
do matter, and they do get remembered always.
Yeah. We've been also having a lot of conversations around that, like client directed care aspect,
Mm.
and yeah, making people not making people feel less than, and recognizing those small gestures. And it, even the little, not little, but the very achievable example you gave of helping someone if their pants are falling down so that they have that dignity during a really probably terrible moment in their life. That is such a
Yeah,
small thing, but yeah, gives such, get like really maintains our humanity, hopefully, to some extent.
absolutely.
Yeah. Um, the question that I'm very curious to hear your response around is, we've talked a little bit about like pain management, maybe more from a physical disability perspective, but I'm really curious how you witness ableism and saneism showing up in the ways that institutions approach drug policy, health equity, like this whole space. Like, how does maybe more on the mental health condition side of the
Mm.
spectrum, or the developmental disability side of the spectrum, like how do you see that showing up in your work?
Oh, that's a really good question. Almost like I flagged it, like I really wanted you to ask me. You had great questions on the list. I'm so excited. Saneism is one of the biggest things that I would say puts an impediment to people receiving dignified and timely care, especially when we're looking at the context of somebody using substances and somebody who is experiencing some kind of medical related result, something from using substances. People have the right to use whatever they want. They can do whatever risky behavior they want to do in life. They truly have that right. If you want to take a lot of drugs, you have the right to do it. And then we will respond when the implied consent portion kicks in, which is when someone becomes non-responsive. If I walk up to somebody who I know they've taken a hit, absolutely. And I know they've taken a lot and the drugs are hitting really hard. They're cut with some nasty things. And I know they might OD. They might overdose and might require a shot of naloxone, but they are awake and I say, "Hey, you all right?" And they go, "Yeah, go away," or "Yeah, I'm not going to be sticking anything up their nose. I'm not going to be touching them. I'm not going to be encroaching. What I'm going to be doing is sitting my butt down across the street if I have the time and I have the gut feeling that this is going to go poorly. Or maybe I go and I do an errand and I come back in 10 minutes and I'm going to check. And in 10 minutes, if they're down and out, I will, the rules of implied consent rather, come in. And that is the point of response. The assumption that because somebody has taken a drug and is currently high or under the influence of anything, that they are still able to communicate, but their communication is wrong, is so heavily rooted in the idea of the clear mind and the idea that your mind is unimpeded or unbothered by substances or unbothered by an impairment, be that a cognitive disability, an acquired brain injury, being born with it, or having difficulty articulating it. We also see this massively when people have a language barrier of any kind. We assume they are incapable, and that is, oh, I'm all riled. That is infuriating. That is unacceptable. And that is beyond the rights of anybody to interfere with someone else. When we're looking at, for example, somebody might present to an emergency department. They've had a prescription for opioids, they've accidentally taken several, and they have a cognitive disability where this is an issue. Instead of speaking to someone and going, "Yeah, it's a mistake you can make. It's a mistake anybody makes." Many people make this mistake. Accidental overdose of prescribed medication by people who are not considered having a substance use disorder is a major problem, not because people are trying to hurt themselves. It's just an accident. And instead of speaking to somebody as, oh, they're too incapable, they're too intellectually inferior to actually understand the complexities of the situation, you go, no. When was the last time you accidentally forgot to take your med or you forgot? to give your kid their ADHD med, and now it's 2 hours later, and you send them to school, and you got to do the walk of shame, or you bring the med, or you got to call up the school nurse and hope they've got the rest of them. There's so many moments here where you got to not assume that just because somebody is impaired to some degree, or you perceive them to have an impairment of some degree, that they are not responsible with their dangerous medication. No, your job is to work with somebody. And so this assumption that somebody is not strong enough in a capacity way to do something that they have every right to choose to do is an incredibly dangerous thing. And it leads to people not getting the pain management they need. You can look at nursing homes as well, the conversation of people with dementia in assisted living or in long-term care not receiving the pain management they need because the articulation of needing that pain management is not at the standard, apparently, that someone has been trained to perceive, or the articulations of somebody who is having a cognitive difficulty explaining that pain. The management of somebody who is having a sensory or a neurosensory issue, even articulating the type of pain. So many people with different kinds of either what would be considered more a higher support need or a lower support need struggle with that. And being able to have that pain management is a vital part of living and thriving.
It's I'd never thought about it in the pain management, like from a pain management perspective, but every time we onboard a new personal care attendant, one of the questions we ask them is, what does a client's right to risk mean to you? And
Ooh.
99.99999% of the time, the personal support workers and attendants we are interviewing have never heard of this concept. So we
Mm.
usually end up having to give examples of we had a real life situation where a client was getting help eating dinner from an attendant and a piece of food fell on the ground. And the client said, I don't care, I'll eat it. It's fine. And the attendant said,
Mm.
no, the floor is dirty. You can't have it. I'm a healthcare worker. I have to protect you. And the client was like, I'm a 50-year-old lawyer. If I want to eat food off the ground, I damn well can. So it was, again, a very small thing, but like a very impactful thing to happen to her dignity and to her right to determine that risk level. And again, a piece of food falling on the ground is like a whole different conversation, but the same thing goes in attendant care. If someone wants to have another beer and you don't think they need more beer, if they want you to pour them another beer, you're just their hands pouring the beer. You're not there to make judgments. You're not there to do their risk assessment for them. Like, you are just there to assist them with the tasks that they need assistance with. So communicating, I do find that challenging sometimes to communicate that to people who have come from a very traditional healthcare setting and are
Absolutely.
I'm the risk, I'm the patient safety, I'm the risk assessor, and they take that perspective.
No, they definitely do. It's such a frustrating thing watching someone put in their position the statement of, I am here to help you with X whatever thing that you either hired me or contract, or we're here to have this collaborative moment.
Mhm,
I now have the right to collaborate with you on everything rather
mhm,
than, no, we're here for this. My dignity and privacy. You're not here to touch me like that. You're not
mhm,
here to have a conversation around how well I control my spittle.
mhm,
This is a ridiculous issue
mhm.
here. You're here to assess my liver function.
Yeah,
Chill.
yeah, yeah. It's a I think part of me has a bit of empathy for the healthcare workers who I think are the liability and the legal risks and all of that, like
Mhm.
policy and stuff is really drilled into their brains. So undoing a lot of that sometimes I think takes a lot of time. Um,
Definitely.
I'm going back to that tension. Like, I'm curious how you've been doing so far and how you think you're going to do moving forward as you enter the like pinnacle of policies and institutional procedures and rules and regulations. Like, how are you going to, or how have you in the past, and how are you going to continue balancing that like human centered perspective and the dignity of people and stuff while potentially navigating a more structured, or I don't think structured is the right word, but like a more rigid environment that's not necessarily built to accommodate people's self-worth, or I think that's the right word. I don't know.
That is the right word. I would honestly say it's the right word. A very strange thing happens when you're either going out for this world and you're saying to people in medical context, I'm going to go be a family doctor, or I'm going to go be a doctor, like you, is the unsaid word, of course, when you're speaking to a medical doctor or a nurse. And once you've entered that fold, you're brought in a very strange, it is a very strange sensation. I've spent a lot of my life around the medical world being either the patient or being the advocate or being back in my prior in a formation being the wife and now being perceived as somebody's male partners. All of these different sort of connotations in a healthcare setting are different. It's like a different world in each of these changes. The minute that I truly was able to say, and I am going to medical school, it changes everything about how a physician will speak to you or how a current healthcare worker will speak to you with the assumption of you're one of us. That schism is difficult. It is difficult to enter this world and be reading the books where I was saying to muttering to myself and saying to my partner the other day, I'm reading this genetics book and oh man, there's the R word and this is 2013. We didn't need to call it that. We had changed the name of this already. Okay, great. This is an extremely racist book. How nice. I'm trying to learn about skin lesions. The way that this is structured and watching clinical examinations that can be very traumatizing to the people experiencing them and watching how these information, how this teaching is unfolding with this obsession of stating things like you have consented the patient. Tell the patient what you're going to do. And I'm like, yes, tell them. How do you know that they are comfortable? And they're like, make sure the patient is comfortable. How? We're not talking about this. And there are many people in healthcare worlds who have learned wonderful tricks. A doctor who I learned quite a lot about refused to stand when he spoke to patients. He would sit, he would delay the conversation with idle chit chat, looking for a chair so that he could sit down and speak at a seated position when someone's in a bed or when someone is sitting so we can have a conversation with respect and dignity and we can all understand we're here coming to the table. And so that is something I will never deviate from. I will sit, I will take a knee, I will crouch. It's important to me. So there will be things that I will do that are beyond what is considered acceptable that I truly dare anybody to argue with me. I dare them because I'm old now and I'm crotchety. And I truly dare someone to tell me to not be kind.
If they do, I hope someone records it.
Oh, it'll be a wonderful moment in my life of trying to keep a license.
That's yeah, I'm excited for your journey and curious to hear in a couple of years how it's going. We've
We'll
talked
talk then.
yeah. We've talked a lot about some of the bigger themes, but I'm wondering if there's anything we've missed in our conversation that kind of ties this back to the disability justice element. Like we've talked a bit about pain management and sanism, but is there anything else that you'd want to highlight for folks around the intersection of the opioid crisis and pain man, just anything that people should be aware of that you don't think is being communicated well in the stories or the narrative we hear about drug overdoses right now?
Yeah, that's a really great question. So, substance use disorder, which is the current term for I use substances and have difficulty stopping, and it's impeding my life. That is the definition. It causes some issue, and I'm having difficulty stopping when I would actually, when I think about it, I'd like to stop. So it has to have those characteristics. So, substance use disorder. That can be alcohol, that can be fentanyl, that can be like heroin's not as popular anymore because we have synthetic opioids, much stronger, much cheaper, lighter to transport. Good times. It can be cocaine, which is very expensive. It can be crack, which is less expensive. It can be all sorts of anything you want. Substance use disorder is absolutely in Canada, in the United States, by the World Health Organization, defined as a disability. This is a disability. It is a disability. The people experiencing it are disabled. That is, to me, so cut and dry. And the way that we treat people with disabilities is abhorrent. And it is no more, it is so absolutely blatantly viewed how we view disabilities by looking at how we treat people who use substances or have a substance use disorder. The way that we strip them of access to safer places to use what they need to do in order to not hurt themselves. We have banned Canadian nurses, North American nurses, from putting a needle in someone's vein so they don't rip their veins open and have an extraordinary problem. That is a healthcare expenditure. The damage that occurs to the veins, the damage that occurs to the body, this doesn't need to happen. Your professional should do your injecting for you. We do not allow peer-to-peer injections in most places. Now, if you are a disabled person with a different kind of disability or perhaps a mobility disability, but you also have a substance use disorder, and you need to inject your drugs, or you are going into withdrawal, and withdrawal is excruciating. That is an excruciating experience, and it's dangerous, and you very well much could die. And that sucks because people don't die overwhelmingly from what I understand of life. You, when you go to a supervised consumption site, the few that are left, 10 have closed recently, very dangerous. You are not allowed to have your friend, who is your helper, who is your partner, do your injecting for you. Peer-to-peer injection is one of the safest and best things if you're not going to allow healthcare workers to do it, to strip your friend of the ability to do it. That would be like saying, my partner would help me do toileting, but they're not allowed to help me do toileting. I have to wait for my healthcare worker, who now by the government has been told that they can't help me do toileting. I can only do toileting in a facility? Prescribed? What is happening? It's not, it doesn't make sense. So to strip that dignity, strip the privacy, strip the ability to be in a community with people, to be in connection with other people, to have access to medical equipment that is not on the ground, that is not got other people's blood on, that is not a needle that is pulled back and is essentially a hollow metal tube that you're stabbing repeatedly. I'm terribly sorry. I'm very visceral about this. But to have access to sharps that are sharp, to have access to a sharps container, to have access to medication that is not full of horrible additives that are going to take you out real fast, to be able to have your pants on, to be able to do it in a place where you don't have to be around people going to the subway because that on the off chance that someone there might look at you and might stop you from dying because you really need to do this, or you are going to get extremely sick very quickly. The idea that these disabled people are not part of the disability justice movement because they are poor, very poor, and because of the morality that sometimes comes within the disability justice world of who chooses to be disabled or not. We do not have this level of animosity towards someone who suffers a ski accident and is now, whoops, we're part of the disabled community now. We welcome them. And we talk to them about sores, and we talk to them about regaining a little function here and there. We talk to them about adaptive driving. We don't talk to our brothers and sisters, our siblings, who are dying of their disability because we've stripped them down so hard. We are not kind to these disabled people in a way that we, amongst ourselves in the disabled world, extend a kindness to people who deserve it under all that morality. But yeah, the system really blows. And then we're also not really extending a lot of love. And I worry about that.
Yeah. I live in Ottawa's Chinatown neighborhood where one of the safe
Oh, right
consumption
there.
sites closed, and it's recently come to light that the closure was justified based on data they pulled out of thin air. Nobody is really clear
Yep.
where these crime rates actually came from based on an access information request. So I live in the neighborhood that's now impacted by people not having a safe place to be, and it really it impacts everybody. And I
Definitely.
worry about how far we have to go because we have clients who use Whimble to dye their hair because their PSWs are not allowed to use box hair dye. So if a PSW is banned from helping a client dye their hair with box dye, like we are so far away from a world in which they can fully assist with all activities of daily living with no like moral judgment being passed. Yeah, it's a bit scary, but I would like to end on a positive note. And
Yes, please.
because it's really easy to feel like, oh God, there's no way out of this. But and I'll also pause if anyone has a question, feel free to pop it in the chat. But I did want to end on a positive note of what's something that's giving you hope right now. Please just give us like a little shred of hope to finish on.
A little shred of hope. All right, a little shred of hope. I am seeing some fantastic communication and some fantastic work coming down from various scientists in different groups. Like I mentioned, the ODPRN, a group of scientists that I work for, I am the lowly small research coordinator of one small project. I am seeing quite a lot of hopefulness of people who are very excited to work on these topics. I am seeing fascinating ways to handle and get around loopholes. Similarly, in this group, of scientists out of St. Mike's, they created a vending machine for harm reduction materials and were able to place them in high risk areas where they're getting a lot of use. They're putting naloxone, they're putting condoms in there, needles, all good stuff. We could even start putting socks in there. A great time. I am also seeing just an awareness from people who are on the front lines, like library workers, who are like, you know what, I don't want to see someone die. Give me the training. For example, when we started offering this training to library science students, we did it first for a class of 60 of them in their required course. They were stuck there, they had to be there. It was a good time for me. And we did this for 60 of them, and we had about 10 of them who had a bit of a bug about it, and they were very offended. The next year, for some reason that I have no control over, the class size doubled. We had about 140 students, and not one of them had an issue. Even people who were all tight about the idea of, ooh, needle, ooh, dirty people, they were rapt attention while we talked about this, excited to have a method. They were relieved to have something to do, some tiny but effective method. What the hope that I hold and the hope that I always hold is that when you give somebody a tangible solution to an issue instead of just slapping the issues on them, they feel a lot better about it and they have confidence. We did a measure of the students for that 140 strong class. 100 of them participated in it because attrition students, what are you going to do? It was anonymous. I asked them before the training, do you feel confident recognizing an opioid overdose? And do you feel confident using an naloxone kit? Both of those, about 30% said, yeah, I could recognize it. 30% said I could use a kit. Afterwards, we had 80% across the board. It was a 90-minute training. That gives me hope. People recognize it's important because frankly, you can see it everywhere and it hurts and it's painful. And nobody really wants to do that. And if it's out in the open that way, alleviating a lot of the tension of I can't do anything is doing something. Give somebody something to do. And so that gives me wonderful hope. I think people who want to do something, the best thing you can do is find somebody who knows how to do that thing, learn how to do it, whether that's helping somebody effectively and with dignity use the washroom, knowing how to prepare certain dietary foods, knowing how to count the stairs appropriately so you can give your friends a heads up, knowing to call ahead and say, hey, are there flashing lights here? Can I just know for this party I want to bring my pal to? Can you just, oh, there are, great. Can you turn them off? Is this integral? It's not, great. Okay, let's go party. Let's go rave. Being able to just have that empowered moment to contact people and say, all right, I know how to do something. Let's do it. That always gives me
Amazing. Yeah, I love that ending of let's just do it. And it was a reminder I needed to hear today because when I get frustrated and I want to give up, it's no, we've got to just keep going. Thank you so much, Atticus. I feel like I just took like a PhD level course from you, intro level course. And we didn't even get to talk about your accessibility mapping work. So we're going to have to, in all your spare
dang.
time coming up, we're going to have to bring you back for another discussion around that because I also wanted to talk about that. So that'll just let me know when you have a few minutes in the next 4 years and we'll have that conversation.
We'll pencil it in approximately
Yeah.
17 months.
Awesome. But yeah, thank you so much for doing this. I really appreciate it. And I hope you feel appreciated in the work that you do because not many people in society are stepping up and actually doing something to solve these problems. So I'm really grateful that you are actually really tangibly doing, like, dedicating your life to this. So it's really remarkable to watch and hearing your story. I don't know if this is like a problematic reference. I don't know.
Go on.
But you really remind me of like the ultimate Renaissance man. Like you are like Leonardo da Vinci reincarnated, because you're like the musician and the scientist and the researcher. And yeah, I don't know. That really reminded me of like your life up to this point, hearing all the different things that you've done along your travels. So yeah, it's really cool to hear more about your story and more about your work, and love to stay in touch. And yeah, thanks again for doing this, and thanks again for everybody who joined us this afternoon.
Thank you so much. Thank you so much for having me. I really enjoyed it. I look forward to being able to chat with you and with others again. I really love the work that Wimble's doing it, frankly, because you guys do it and you do such a great job. I'm
We're
excited.
just out there just trying to do something to fix these systems. So hopefully we'll all
That's the
succeed
thing
in
to
this.
do.
Yeah.
We'll never really succeed, but we will do something
Yeah.
along the way. We'll make it less crummy along the way.
Hopefully a little less crummy. Yeah. Okay. Thanks, Atticus. Enjoy the rest of your day. Good luck with
Thank
school.
you. Thank you so much. Bye, everybody.
Bye.